So I'm going to talk to you about ADCs in breast cancer, and ADC stands for antibody drug conjugates. Greetings to you from my city, Bangalore in India. So this is going to be the outline of my talk, a little bit about introduction to breast cancer. I'm sure all of you are aware of it. Just to put it in perspective, then talking about how we target some of the things that we are doing routinely, especially the HER2 target, and then look at ER positive breast cancers, and then some basics about what ADCs are, what are the ones that we have today, and a little bit about the resistance pathways that develop when we use ADCs, and some conclusions. So for a long time we thought breast cancer was a single disease, but we have understood that it is not so because of a lot of people working in the lab and helping us. We came to know that we have something called ER/PR positive, and soon we realized that there's something called HER2 positive and a set of these patients who are triple negative. So today we know that breast cancer is not one disease, and it's important that we understand the biology because we need to treat them differently. So this was something said that I can see further standing on the shoulders of giants. Any of the students here know who told this? Okay. This was told by Sir Isaac Newton. So it is important that we actually acknowledge our giants who worked in the past to help us do better today. And when we're talking about breast cancer and HER2 positive breast cancer, that person is Dr. Dennis Lehman, who actually worked on HER2 and showed that this was a possible target, and this was in fact beneficial to use the drug. So what is this HER2? This is a part of the family of EGFR receptors, and there are 4 of them here. And the second one is called HER2 or EGFR2, which is overexpressed in about 30 to 40% of breast cancer patients. And why is this important for us to know is because the overexpression of HER2 is associated with poor prognosis. So breast cancer, we understood that this pathway is important, and the drug that came out was Herceptin or trastuzumab. So we have what is an era before trastuzumab and an era after trastuzumab came in. So what's this drug? This is a monoclonal antibody which targets the EGFR or HER2 pathway and converts a disease which has poor prognosis into a good prognosis disease. So as I mentioned, this was the paper published by Dr. Dennis Lehman in NEJM in 1989, and he showed that the use of trastuzumab along with chemotherapy showed an overall survival advantage. And recently he actually, when he was talking at ASCO, he said one of the patients who was on that trial is continuing to receive trastuzumab even today and getting benefit. Yes, we did find this target, we did find the drug, we did show the advantage, but what happened was almost 50% of these patients who received trastuzumab at first line had progressed after 1 year. And therefore, we started looking at newer targets, and we had this concept of what is known as the dual HER2 targeting in breast cancer. And what is that? This is shown diagrammatically here. We have the HER2 as a target, for which we have trastuzumab to block that, whereas we know that HER2 and HER3 dimerize, and therefore we had another drug called pertuzumab, which again binds to the HER2 receptor and prevents the HER3 from dimerizing. And we know today that the dimerization occurs between all the 4 receptors that I showed you, the HER1, HER2, HER3, and HER4, but the strongest dimerization is between HER2 and HER3, and therefore the concept that using 2 monoclonal antibodies to target this HER2, the concept of dual HER2 blockade was thought of, and we have the data from the study called Cleopatra, which showed that in fact doing a dual HER2 blockade was advantageous to the patient, and this was the overall survival, showing that there is distinct advantage here. This is looking at the timeline of targeted therapies, especially in the hormone receptor positive but HER2 negative patients in advanced breast cancer. I'll not go through all this that is on the slide, but I'm sure most of you have been in the era that has seen these developments happening. So the ESMO ABC5 guidelines talks about the role of ovarian function suppression in premenopausal women, and the consensus for this was 93% at this guidelines meeting, with a level of evidence as 1 and grade of recommendation of A. So this is the highest level of evidence and recommendation that you can have in any guidelines. So this is just to show you that when these patients are treated with hormone therapy, ultimately they develop resistance, and this is just to show you that over time we have been targeting the ER/PR positive patients with either tamoxifen or aromatase inhibitors or the estrogen receptor downregulators, and now we have a group of drugs called the CDK4/6 inhibitors here. And this is again to show you that with treatment the pattern of these patients change, and therefore we are now looking at the use of a new group of drugs called the ADCs. So what are these ADCs? These are nothing but the same monoclonal antibodies to which we attach chemotherapy drugs. And these chemotherapy drugs are nothing new, but these chemotherapy drugs have been tested in the past and they were put away in the shelf because of their toxicities at the therapeutic doses that they were effective. But today, because of this concept, we've been able to get these drugs back and use in smaller amounts with which we have reasonable toxicity that can be taken care of. So the components of the ADC is that there is an antibody, there is a linker which links this to the chemotherapy drugs which we call as payload, and this is just to show you that we have a group of different drugs that are being used. So how do these drugs work? That this particular monoclonal antibody attaches onto a target that is there present on the tumor cell, that gets internalized, and once it's internalized, the linker releases the chemotherapy drug which brings about the cell death, and some of this gets leaked outside this tumor cell, and that leads to some of the cells around as well getting killed, which is called the bystander effect. So the first one of these antibodies was the TDM1, and this was popularly called the Trojan horse concept. I'm sure you'll remember the mythological story by Ilias, who talked about the soldiers being hidden in these huge horses which were sent across to defeat the enemy. So that is the concept of the ADCs, that these chemotherapy drugs are on the monoclonal antibodies which get internalized into the tumor cell, and that leads to the cell kill. So this is the drug trastuzumab emtansine, and this is the HER2 targeted antibody drug conjugate. So these are the two studies, the Emilia and the Teresa, which showed that it was beneficial as compared to using of the chemotherapy agents when TDM1 was superior to them. This is a study in which these patients were naive to the targeting of HER2, and this study was post-progression on HER2 targeting. They were randomized to TDM1 or capecitabine plus lapatinib, and as you know, lapatinib is a small molecule which targets the intracellular tyrosine kinase of the HER2 receptor. So this study showed that there was a overall survival advantage when this drug was used, and this is again to show you the advantage from these two trials, the Cleopatra and Emilia one, again showing you that there is an advantage of using this antibody drug conjugates. So because of this, this soon came into the guidelines, and as you can see here, this was for the later lines of therapy. We soon had this drug called trastuzumab deruxtecan, which is a much more potent drug, and that again is because of the payload that is different. And the study that showed that this was effective was the Destiny 3, which looked at the TDXD, that is trastuzumab, versus TDM1, which is the earlier molecule that I spoke about. And these are the two waterfall plots showing you that the responses to the trastuzumab deruxtecan is definitely better than for TDM1, establishing the role of TDX here. And this is looking at the secondary endpoint, which was the overall survival. You can see that even towards the end of the curve, there's a separation that is happening. So this is Destiny 3 again, which was looking at the updated primary endpoint, which was PFS. you can clearly see the separation of these two curves, and that is showing you how advantageous it is to use this new ADC. So this was the other study called the Destiny 4, which was looking at comparing this molecule TDXD versus treatment of physician choice, and this was again a phase 3 trial, and this is to show you that whether they were hormone receptor positive or not, there was an advantage for all these patients. So this is a waterfall plot for you, again giving you a clear visualization of individual patient responses here. So that was targeting HER2 pathway. We now have another ADC called sacituzumab govitecan, which is a first-in-class targeting the TROP2 pathway. And this TROP2 overexpression is seen in several solid tumors, and this is a slide to show you the percentage of positivity across all tumors. In fact, today we don't even need to look at this target, which is actually established by the IHC. So we don't even need to look at whether this is expressed or not, because it is expressed, as I show you in this slide, that it is there in almost all solid tumors. So this was the first paper, the final overall analysis, which was a phase 3 study. The study was called TROPICS-2, which was looking at sacituzumab versus the chemotherapy drugs and the treatment of physician's choice essentially. And this is to show you the primary endpoint by a blinded independent review committee, showing that there was an advantage of using this antibody drug conjugate versus therapy of physician's choice. This is looking at overall survival also, and again there is an advantage here. This is the other antibody drug conjugate targeting the same pathway and with a different payload that is shown here. And this is a slide to compare these to the sacituzumab and datopotamab. These molecules are still not available for routine use. We have to import them even in India. Sacituzumab is available. I've had experience of using this molecule, and we have been doing clinical trials with this as well. So the other important emerging biomarker for targeting is HER3. And if you remember the slide I showed you, HER2 dimerizes with HER3 as one of the most potent dimerization. So this is a valuable target for us. And this is just looking at the HER3 biology. So today we have another ADC targeting this particular HER3 receptor called patritumab deruxtecan, and this is the structure for you. This is a waterfall plot for an interim analysis of use of this molecule in metastatic breast cancer, and that has led to its approval in this indication. So as I mentioned, Destiny is the name for the study of all the trials that use deruxtecan, trastuzumab deruxtecan as a molecule. And this was a study called Destiny 12, which actually was one of the recent studies which was done. Until this study came in, we used to use small molecules like tucatinib to treat intracranial metastasis in HER2 positive breast cancers. And this was the study presented recently at the ESMO Barcelona. And this study actually showed that although we believe that large molecules like the monoclonal antibodies do not cross the blood-brain barrier, this study showed that this was not true. And this drug trastuzumab deruxtecan had a good intracranial activity. So after that, the discussant Christina, who talked about the study, showed this change in the algorithm, and now trastuzumab deruxtecan has become an important drug even before the tyrosine kinase inhibitors to take care of the intracranial metastasis in HER2 positive metastatic breast cancer. So again, just to remind you of the EGFR or the HER2 family, and as I showed you with all the drugs that we have advantage, but like most drugs that we use, we see resistance happening. So how do we look at these resistance pathways? We have understood that this could be because of alteration in the HER2 receptor. One of the important things that we call is truncation of the HER2 receptor, by which the receptor loses the extracellular domain and acts only through the intracellular domain, wherein we can't use monoclonal antibodies. We need to resort to the small molecules or the tyrosine kinase inhibitors. Other one is by hyperactivation of various downstream signaling pathways. variation in the host tumor immune interaction, and one of the other pathway is this CDK4/6 pathway. So understanding this, we have this trial called the MONARCH-HER, which is using a CDK4/6 inhibitor, that is abemaciclib, with HER2 targeting, and this is a study. And this showed that the investigator-assessed PFS, which was a primary endpoint, was met. So there is an advantage of targeting the CDK4/6 pathway along with targeting the HER2 pathway. So you must be wondering why I'm showing you horses. We are just bringing out a book on the antibody drug conjugate, and I've been given the task of writing the editorial for this. And you remember the Trojan horse that I told you about? So I was just looking at what we can give as a title. And interestingly, harass is the term that is used to describe a herd of horses. So what I said was, I will make this as a title saying, "Cancer beware, harass of Trojan horses are coming." So what we now have is, I showed you the ADCs which we have been using now, but what's now happening is we are having bispecific ADCs, and this is just to show you the several targets that we have that are under investigation, and these things is like having many Trojan horses attacking our cancer cells that we always want to kill, and that's why I showed you this slide of horses. So with that, I think I will stop, and thank you very much for a patient hearing.